All right, so welcome back. All right, so as far as the body's response to shock, again, because the body's not getting perfused adequately, let me do one thing real quick. Because the body's not getting perfused adequately, we've talked about what's going to happen. We're going to have the vasoconstriction. We're going to have the increased heart rate, increased respiratory rate. The force of the contraction is going to get harder because of that vasoconstriction. Now, what hormones are going to cause the body to do that?
The adrenaline glands.
Okay, the adrenal glands are going to release which ones?
The epinephrine.
Okay, and?
The non-epinephrine.
Non-epinephrine.
Norepinephrine.
Sorry.
Yeah, it's norepinephrine. And then the other hormones are going to be released. They're going to decrease urine output. They're going to cause more vasoconstriction. They're going to increase heart contractility. In other words, the heart's ability to be able to push out blood harder than before. And more glucose into the blood. Because why is that body going to need that additional glucose?
Energy.
Yeah, to get more energy. Okay. All right. So, as far as the stages of shock, the first stage is going to be what we call compensatory shock. In other words, my body's going into shock. We know my heart rate's going to go up, respiratory rate's going to go up, vasoconstriction, blood pressure's going to go up, increased systemic vascular resistance. And so my body is compensating. It's putting up with it. It's able to keep up with the demands that it needs. Unfortunately, what's going to also end up happening is just like, it's been a long week. You guys have been getting up early to come to school and everything else. Have you gotten tired?
Yeah.
We know the body gets tired. And that's what's going to lead to the next stage, which is decompensated shock. So in compensated shock, the body's putting up with it. We could reverse it in compensated shock to bring it back down to normal. Yeah, there's going to be some changes, but the body's still keeping up with it, but we can still reverse it. Now, understand that the first sign of shock is going to be tachycardia, the rapid heart rate. First sign of shock is going to be tachycardia. Now, let me give you guys a visual, and if you look at your PowerPoint, slide 47, how it kind of goes in circles, you have blood loss from a laceration. Think about the analogy of circling the drain. You know what I mean when I say circling the drain? In other words, as you take out the stopper, or you open up after you take a nice hot bath and you start letting the water out, as it gets closer to the bottom, you see that water just spinning right there in its place as it's going down the drain. So that's the analogy we use, is circling the drain. And so as the blood loss continues, first off, we have the rapid heart rate, the rapid respiratory rate, the vasoconstriction, the increased near normal blood pressure. It might go up just a little bit. But as more and more blood is lost, the less blood / water remains. And so the problems start getting worse. Now the heart is having a hard time keeping up, more volume, the pressure is going to start to drop. And think about the blood flow going to the brain. What happened to that blood flow?
It's gonna start decreasing.
It started to decrease, right? And so how much energy is the brain getting in order to function?
No.
Not very much. And so the patient starts becoming lethargic. Your pulse is going to start increasing even more. So in compensatory shock, your pulse will be under 120. But as the body starts to tire out, now you're going to have blood pressure start to decrease or hypotension. So know that hypotension is a late sign of shock. It's going to be a while before we start seeing that blood pressure drop. The pulse rate is going to go up. Because it's getting harder and harder for the heart to work, but it's still trying to get whatever it can. So if the brain is not getting enough oxygen, what's happening to the other organs?
You're shutting down.
They're going to start to fail and start to shut down.
The MODs.
Huh?
The multiple organ dysfunction.
Oh, yeah, we'll start getting organ dysfunction. It's basically organ failure. And so really, when we get to organ failure, we're in what we call irreversible shock. We can't reverse it anymore. We can still reverse it in decompensated shock. It's going to be a little bit of a tougher battle, but we can still bring them back down, give them fluid, give them oxygen. They get blood. The doctors could go in there and repair, surgically repair whatever is wrong. But if too much time goes by, then in the irreversible shock or multi-organ dysfunction syndrome, those organs are not going to be brought back. And so they start to fail. And remember what we talked about with cells, when they die, they release the contents and they destroy neighboring cells. And then, so by this point, the patient will be unresponsive. They'll be really hypotensive. No matter what you do, their pressure doesn't go up. And so it's kind of a domino effect. One organ fails, and the next organ fails, next organ fails. So the more organs start to fail, the higher the likelihood of the person dying. Now, one of the things in your assessment is look at your mechanism or your nature of illness. If they've been sick and they have a fever, you got to think about maybe septic shock that hasn't been treated. It's now circulating throughout the blood. With trauma, where is the injury at? Remember when we did the abdominal quadrants? I talked about knowing which organs are in which quadrants and also knowing which organs are hollow versus solid. If a patient has an injury to the spleen, what's the danger?
Bleeding out.
Blood loss.
Bleeding out. Because remember that the spleen is a very vascular organ. It's a solid organ. So we should be seeing signs and symptoms of that shock. Even though we might not see the bruising right away, they'll have other things going on. The tachycardia, maybe the elevated heart or pulse rate. Blood pressure, pale cold clammy skin, severe upper left quadrant pain, maybe pain to the shoulder, to the back. Now, this is just a little pearl for you guys to know. When you're doing your assessment, when you're doing your medical history, or more of the medications they take. Be alert for medications that are called beta blockers. They usually end in LOL, LOL, like metoprolol, labetalol.
Prednisol.
What's that?
Prednisol?
No, that's prednisone.
Oh, never mind.
No. The LOLs are beta blockers. In other words, they reduce the force of the contraction of the heart and they slow down the heart rate. It's used for high blood pressure. So, what did I say the first sign of shock was?
Tachycardia.
Tachycardia.
And if beta blockers slow down the heart rate, are you going to see tachycardia with shock?
No.
No. So that's why you need to make sure that you look at the mechanism. Should this patient be in shock? And we'll talk about that in trauma, but if you feel like this patient should be in shock, yet they're not showing signs and symptoms of shock, just treat them for shock, especially if you don't know really what the meds are. Just treat them for shock. Okay. So on the vitals, get your pulse, get your respirations, get your blood pressure, get the level of consciousness. How often do you think you're going to have to reassess the vitals on this patient?
Every 5 minutes.
5 minutes.
Every 5 minutes. Okay. Every 5 minutes. Get the skin signs. Get a pulse ox. See what the pulse ox is doing. Now, what you don't want to see your patient doing, like I said, you don't want to see them altered. You don't want to see them lethargic. Pale, cold, clammy skin's going to affect it. The other thing too, the pulse. Remember, we mentioned that you're checking for the rate, rhythm, and quality of the pulse. Well, a patient going in shock, what do you think the rhythm and or more the quality of the pulse is going to be?
Perfused.
What was that?
Weak.
Weak. Yeah.
Yeah, it's going to be weak. It's going to be a weak pulse. Now, elderly patients and kids. Kids are very resilient. They will compensate very, very well. The problem becomes when they stop compensating. They will compensate on you very, very quickly. So keep an eye on them. Now, for old people, because as we talked about before, the body starts to degrade, so things might not be as obvious for a while. So again, having a high index of suspicion, looking at that mechanism, thinking about what might be going on. The other thing is elderly patients are on a lot more types of medications that will have an effect on circulation, on the heart. Medications will mask things like that. And then their mental status and their respiratory rate will be higher. And that's more profound signs of shock in the elderly. So keep it on them. So what do you think our goals are? So again, I'm in shock. You guys are treating me. What do you want to do for me?
Ventilate if necessary.
Okay.
O2.
If ventilating, what do you want to do?
Non-rebreather.
All right, throw me a high flow O2, 15 liters via non-rebreather mask. or 12 liters. What else?
What was your scenario?
What? I really didn't give a scenario. I just said, I'm in shock. How are you going to treat me?
Give you oxygen, check your vitals to see if you need any kind of medication besides oxygen.
Okay. So scenario is my girlfriend got mad at me. She took a kitchen knife and she slashed my brachial artery. So I'm bleeding out. You did my vitals, pulse rate of 116, respiratory rate of 24, blood pressure of 130 over 84. My skins are pale, cool, and clammy. Am I showing signs, symptoms of shock?
Yes.
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 Yeah.
Yeah.
So what else are you going to do?
You're in obstructive shock.
Bleeding.
No, it's not obstructive.
You also stop the bleeding.
Stop the bleeding, right? I'm bleeding out. Well, before you get to a tourniquet, what are you going to use?
Pressure with your hand.
Pressure.
Apply direct pressure. And if the bleeding's not controlled, then you would use a tourniquet.
How long can you leave a tourniquet in place?
Several hours. What if instead of slashing my brachial artery, she stuck me in the ribs with that knife?
Possible.
What are you going to do then? What do you think you're going to do?
O2.
O2 BVM.
Okay. Like, think about Steve Irwin, the crocodile hunter. How did he die?
From a stingray.
Puncture one went in and it was removed.
Stingray punctured his heart. When the stingray removed its tail, it left a hole in the heart. So what happened?
Bled out.
He bled out.
So you secure the knife wound as well so it doesn't move around.
There you go. That sounded like Josh.
Yeah, buddy.
Oh, you are awake.
Surprisingly.
I know. Except I don't see his face.
Oh. Are you still in bed?
I'm trying to find him here. Josh's last name Rodriguez.
Yeah.
I don't have you on camera.
Why do you look like you're waiting for a photo shoot?
Wait, I'm like, I'm what?
Posing for you.
You don't see him, Lou?
Nope.
He's posing for you, Lou.
I'm almost afraid to ask how he's posing.
Oh man.
Recovery position.
As long as not the knee chest position, I'm happy.
Oh man.
I got 9 screens up. I only have 4 people on. And I'm missing Josh over here. I'm getting ready to throw this computer away. Make it think too much. It's really slow. So anyway, all right, here we are. I see head out of those wall and ceiling. I see Paul's hat.
More of his forehead.
Well, now I see his forehead. Before it was just his hat. That's
Josh,
nice lines, though. All right, so going back. So yeah, impaled objects you don't want to remove. You could actually make more damage when you do remove them. And there's 4 things, and this goes to your bleeding control skill. You control the bleeding, and then there's 4 things you need to do. Remember these 4 things. Number 1, properly position the patient, which is supine, and elevate the legs. Supine, but you elevate the legs. You want to cover them up. You want to place high flow O2, which is 15 liters via non-rebreather mask. There's Josh. And the last thing is rapid transport.
What was
No,
the
it's
second
only
one?
4.
cover
Which-
them up and place high flow of O2 of 15 non.
15 liters.
Yeah.
Remember the dose is liters, so 15 liters. So properly position the patient supine with legs elevated. Cover them up. High flow 2 via 15 liters non-rebreather. And rapid transport. Now, remember in the secondary assessment, we were talking about why we do that rapid trauma assessment to look for and control anything else life-threatening that we didn't catch in the primary. And I talked about bleeding in the femurs, bleeding in the pelvis.
Yeah.
So what we
Yeah.
want to do is we want to splint any fractures. That's going to help control the bleeding. Now your book, I know the PowerPoint says apply PASG according to protocol. That's the pneumatic anti-shark garment. No, we don't use that anymore.
How old is that?
Well, the thing about we also call it the mask suit, military anti-shock trousers. PASG means pneumatic anti-shock garment. That's been going in and out of protocols for years. Sometimes it gains favor, sometimes it goes out of favor. Right now, we're not using it anymore. Even the state of Texas got rid of it. We had to teach you how to use a mask suit, which really, you can't use it unless you're under the direct supervision of a paramedic. And all you do is you put it on them. There has to be reasons why you're putting it on. And then you inflate the legs first until you hear crackling or you have a blood pressure of at least 90 systolic. And then you inflate the abdomen unless the patient has a impelled object in the abdomen, is pregnant, or has an evisceration. You apply, then you put pressure on the abdomen again until you hear crackling of the Velcro or the patient has a systolic pressure of 90. It's just like the pilot's suits, the flight suits.
Yeah.
Those things are on their legs to keep
Well,
blood or
seen
fluid out.
The trouser pants ones.
What was that?
I seen the trouser pants or whatever. I
Yeah.
seen ones where they inflate.
Yep. That's what it is. That's exactly what it is. But again, an EMT can only use it under the direct supervision of a paramedic. However, we don't use them in Texas anymore as of last year. And the last time they made this book, they were using it again, but it's hardly ever used. It's like most everybody agrees this should go by the way of the dinosaurs.
No comment.
Not me, silly. All right. The next part is resuscitation, which deals with CPR. I normally don't do this section because you have CPR or you've had CPR by now. However, we haven't had CPR yet. And I kind of feel like I still don't want to do it. And I could recreate your guys' exam to eliminate CPR stuff. But I will wait for you guys to tell me what you want to do.
When do we actually? Weren't we supposed to do them online?
Yeah, I started giving out CPR books yesterday.
Uh-huh.
I didn't give it to the first group. But yeah, we're going to be issuing out the codes for you to take the CPR class online. We have the CPR books that you guys should read before you attempt the class. And then we'll bring you in groups of 6 to do the CPR class.
Okay. Can we come in tomorrow to get the book?
Yeah, you could ask Vianney or Michelle. I won't be here.
Okay.
Actually, I take that back. I'll be here tomorrow afternoon for the night class. They're doing skills again tomorrow.
Okay.
So I'll be here. I should be here no later than 3.
All right.
I'm trying to be here between 2 and 3 o'clock because I start at 3:30 with skills. So yeah, you guys can come in tomorrow. If it's before 2, ask Vianney or Michelle. I think Michelle will be here tomorrow at that time.
Okay.
If not, then I'll be here for a little bit and then do that. There'll be nobody here on Monday. It's a holiday, one of our holidays that we actually get to close the office for. So, nope. No Monday. But just real quick on CPR, and I will I'll redo the test so that way you guys don't have a CPR component of it. But what we're trying to do with CPR is we're trying to do for the body what it can't do for itself. Because CPR, cardiopulmonary resuscitation, is using both, or I'm sorry, is giving oxygen to the body and then pumping that blood out that has oxygen to the body. So the body's not breathing right now, we're going to breathe for the body. The heart's not pumping right now, so we're going to pump we're going to pump the heart. So it's doing for the body what it can't do for itself right now. That's the goal. The importance is number one, starting CPR early, but also defibrillating early, because the most common rhythm that a patient in cardiac arrest is going to be in is what we call VFib, ventricular fibrillation. So let me kind of show you real quick. Damn computer.
Maybe that's a sign you need to update.
She's after you today.
Yes, she is.
I only have my coffee, so, and food.
You didn't know that? Hello?
All right, you see my PowerPoint?
Yeah.
Yeah.
I'm trying to do the slide, but it's really, really slow. All right, there we go. So the AEDs, automated external defibrillators, or they're actually semi-automated. They're only programmed to detect two rhythms. The first one is what we call ventricular fibrillation, or VFib. And all it is just a chaotic rhythm. Basically, the ventricles are freaking out. Another way to think about it is picture a bowl of Jello and jiggle that Jello. Can you see that jiggling?
Yeah.
All right. That jiggling of the Jello is exactly what VFib is. It's just the ventricles are jiggling. There's no pumping action occurring. So that's why you have this sporadic or chaotic electrical release, the squiggly line right here. Now, the other rhythm it recognizes is what we call VTAC, or ventricular tachycardia. So it's not chaotic, it's just fast. The ventricles are going really, really fast, as you see right here. Well, do they have a chance to refill quickly? Or to refill, period? Refill fully.
No.
No.
The ventricles are firing off very fast. Now, with this particular rhythm, the patient may either be alive or dead. I've had two patients who were alive in this rhythm. More often than they're not, they're dead, but I've had two patients alive that were in this rhythm. Rhythm that the AD does not recognize is asystole, or flat line, even though it doesn't look that flat, but there's no electrical activity going on. So contrary to popular belief and movie depiction, you cannot shock asystole. There's nothing to slap around. So once we're dead, this is going to be our EKG tracing. No electrical activity whatsoever. Okay. All right. So like I was saying earlier, the goal is to do for the body what it can't do for itself. We want to start compressions. We want to apply the AD. Know that for every minute that goes without AD and compressions, the chances of survival decrease by 10%. So if you could defibrillate in the first 2 minutes, what are the patient's chances of survival?
Not likely.
Now, after 2 minutes, They decrease 20%, so they have an 80% chance of survival. What about 5 minutes?
50%.
50%. What about at 8 minutes?
20%.
20%. What about 10 minutes?
No chance.
No chance.
Can you see them again?
Huh?
Can you say them again?
I was just giving you math problems. The chances of survival decrease by 10% for every minute that goes by without CPR and or AED. So if 2 minutes have gone by, the chances of survival are 80%. At 5 minutes, 5 times 10 is 50%. So you have a 50% chance of surviving. 8 minutes without it,
20%.
20%. At 10 minutes, 10 times 10 is 100, minus 100 is 0% chance of surviving. The only time you could use an AD or apply an AD is if the patient is what we call pulseless and apneic. In other words, they have no pulse and they are not breathing. All right. So that's the big gist of it. More detailed, that's covered in CPR. And so I will eliminate that from your doohickey. All right, any questions on shock?
No.
Okay. So just remember the rapid and progressive degeneration of vital body function brought on by inadequate tissue perfusion of oxygen. What are the types of shock or the categories of shock?
Cardio.
pH.
Doc.
Just
DOCH.
distributor,
Uh-huh.
Constructive.
distributive, obstructive, cardiogenic, hypovolemic.
There you go. Now give me different types of shock.
Septic.
Uh-huh.
Hypovolemic.
Anaphylactic.
Paul?
Anaphylactic.
Anaphylactic.
Burn.
Yes.
Burn shock.
Neurology.
Hemorrhagic. Is it hemorrhagic? Is that how you say it?
Hemorrhagic.
Hemorrhagic, neurogenic, cardiogenic.
Burn shock.
Okay.
Non-hemorrhagic.
Metabolic shock. Respiratory shock.
Give me types of obstructive shock.
Tension.
Blood clot.
All right, tension pneumothorax. Was that you, Miss Valeria?
Yes.
You're so quiet and shy. All right, so we have what did you say again? Sorry. All right, so we have pulmonary embolism. We have
Hemothorax.
nod, and we have a tension pneumothorax. What's the definition of obstructive shock?
Obstruction of the blood flow. The flow.
Okay, obstruction of the what?
Flow of the blood.
I'm sorry, I didn't catch that again.
Obstruction that blocks the
Obstruction
flow of
forward
blood.
flow.
Okay, obstruction of blood vessels, so it's an obstruction. How about distributive shock?
A distribution issue.
It's a distribution issue. Okay. And what's cardiogenic?
Infective stuff.
And
It
then
originates in the heart.
Originated in the heart.
Mhm. Just trying to open up the next chapter. What's hypovolemic?
Low blood volume.
Okay,
Low blood volume.
but is it just blood?
No, fluid.
Fluids.
Yeah.
Fluid.
Volume.
So young, you're gonna make all of us yawn.
Too late.
I'm trying to not yawn.
No. Okay, so next up, pharmacology. As EMTs, all we're expected to do is assist a patient in self-administering their own medication. Now, as far as the medications are concerned, there is a limited number. So what are some of those medications?
Nitro, oral glucose, charcoal, Narcan.
Any others?
Aspirin.
Not necessarily aspirin, because that's not prescribed to them. That's over the counter.
Epinephrine.
What kind of epinephrine?
EpiPen.
In an EpiPen. Okay. Any others?
No, hydrochloride.
Which one?
It's Narcan.
Uh-huh. Any others?
Albuterol.
Oxygen. Oxygen.
Okay, oxygen. Well, that one, we're not going to help them self-administer it. We're going to administer that one, but that's an exception. But the question was for albuterol, how can we assist the albuterol? Can we do a nebulizer treatment? Huh?
Yes.
Nebulizer and inhaler.
Dose inhaler
No.
or small volume nebulizer.
nationally speaking, a nebulizer, no, because you're putting the medication into the chamber.
Don't you need a doctor's order for that?
Exactly. So nebulizer itself, it's no. With a handheld nebulizer, yes. Now, remember, Texas is different. It's a delegated practice state, which says the medical director determines what you can do. So in Texas, if your medical director allows you to administer albuterol via a nebulizer, you can. If you're while you're here in the program in EMT school, and you ride out with me and I have to give a patient a nebulizer treatment, then I'll have you set it up. You just show me that to make sure that it's albuterol, and I'll let you pour it into the chamber and give it to the patient. Okay. So that's why we teach you how to do a nebulizer, how to set it up. But nationally, and that's how National Registry is going to be, is nationally, you cannot administer albuterol via a nebulizer, only via handheld, a meter dose inhaler. So that puffer thing, although you guys didn't see it, I brought it out for the night class. Paul forgot to get it, I think, maybe.
No, I think Paul did for us when we're doing our skills, the first
Okay.
class.
Okay. So, so medications in general are something that's used to help remedy a problem, or even an illness. So it's something that's going to alter the body in one way or another, chemically, usually chemically. Now, a medication is something that's prescribed by the doctor, whereas a drug really could be anything, any type of chemical substance. So you have illegal drugs, which like cocaine, marijuana, those are illegal drugs. They're chemical substances that are altering something. Now, they could also be used to prevent or treat a disease or a condition. Medication, again, it is a drug, or it can be any other substance. When we're talking about pharmacology, we're talking about the study of medications, study of drugs. So what are those drugs? What can they do? And what can happen if they're not given correctly? Or even what can happen when you do give them correctly? In other words, what is the expected action on the body? And also, what are the adverse effects, also known as the side effects? For example, Paul talked about nitroglycerin, right? What would happen if you put a nitroglycerin tablet in your hand without wearing gloves?
You could get some of the powder into your bloodstream,
And then,
You get a migraine.
and then you get high.
so you get a migraine, maybe a migraine, but yeah, you get a nasty headache. So what we have to make sure we do is that we're doing it correctly. We're only going to do it under the direction of physician. There are gray areas. I don't know if I've told you, but EMS is not black and white. There's a bunch of shades of gray in between. So we have to make sure we do it under physician's order. And we can only do those medications which we're allowed to do. Don't do anything beyond your scope. So in other words, you're probably not going to be administering morphine or fentanyl or any of those controlled drugs. So our primary job as EMTs is to assist the patient in self-administering their own medication. We're getting it ready, we give it to them, they take it themselves. Whereas administering is we're actually dispensing it and giving it to them. And as EMTs, we can't do that. So what can you tell me? So speaking of medications, what can you tell me about oxygen?
It's odorless, it's tasteless, it's colorless,
Hmm?
not in the atmosphere.
Okay, so why didn't I have you bring me a doctor's note to say you can breathe our oxygen?
Because we do breathe 21% of oxygen in the air.
Okay. So how's that different from the oxygen I were to give you if you're short of breath? Again, I didn't ask you to give me a doctor's note to breathe our air.
Wait, what did Rosie say? What?
I forgot.
Because it's 100% oxygen.
No, we breathe 21% of oxygen in the air.
Oh.
Because the oxygen we give our patients is 100% oxygen. Okay. That's different. 100% versus 21%. We do have to be careful with the oxygen that we give or the amount of oxygen we give. We can cause what they call oxygen toxicity. In other words, too much oxygen is going to cause the body to release free radicals. Too much oxygen can release free radicals into the bloodstream, which is going to cause weakness of the cell membrane. So that's why pulse ox is very important. Now, I don't know why Life doesn't have pulse oxes on their ambulances, probably because they can't charge for it. So most of the EMTs get their own pulse oxes. No, that should be part of the standard equipment because we need to know what the pulse ox is before we can give oxygen. And we'll talk about that with the specific medical emergencies. Okay. But we will administer oxygen when the need arises. You just got to be very, very careful with it. All right, who can tell me about oral glucose?
It's a simple sugar.
Okay,
It's found in the blood.
okay.
It's also a primary energy source for the body cells,
And what other cells?
Brain cells.
brain cells.
Brain. Remember, the brain is very, very susceptible to changes in oxygenation and glucose. All right. Who would we give oral glucose to?
Diabetics.
Yeah, or non-diabetics.
When they're hypoglycemic.
Yep. However, what if we don't know if they're hypoglycemic?
You
Can we?
take your sugars.
But what if we can't do a sugar, a BGL? And their sugar, they're hyperglycemic, their sugar is high. What can we do? I'm trying to emulate Josh here.
Mm-hmm.
He's just trying to look pretty and stare at the camera.
Yep. He's showing off his tat so Rosie can take a look at it. Also, not seen the ceiling again.
That what?
We're picking on
Yes.
Josh.
Yeah, so he rotated his camera up to the ceiling so we don't see him.
Shy.
So can we give sugar to a hyperglycemic patient?
No.
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 If we do not know whether they're hypo or hyper, then we could give them sugar. Because if they needed it, cool, we did our job. If they didn't need it, oh, who cares? So they got more sugar. So yeah, if we do not know, we go ahead and give it. Now, contraindications when actually before we even get there. So they're non-diabetic. What other things must we know before we can give oral glucose?
Blood pressure, vitals.
Blood pressure is not that important. Vitals, yeah. How's that going to make a difference?
Skin texture.
Okay. Well, that could help us determine whether they're hyper or hypo.
Blood glucose level.
The what? I'm sorry?
Blood glucose levels.
Okay. So if they're hypoglycemic, we'll give them some glucose. But how do we know, other than them showing to be hypoglycemic, how do we know whether we can give it or not?
Checking their blood sugar, poking their
Asking them.
Okay. So the checking the sugar and something else has been said already several times. So let's figure out. We know they need the sugar. What must be in place in order for us to give them that sugar?
They have to be stable.
The level of consciousness.
Okay. What do you mean stable, Rosie?
As an alert, conscience. I mean.
Okay. So somebody said the level of consciousness. What's that have to do with anything?
Because you can't give no to someone that, I don't know.
Why?
because they could choke on it.
Why?
Because if they're not conscious, you're gonna push something in their mouth.
No airway, no nothing.
Yes, you're gonna obstruct something.
Well, they might have an airway. It's not necessarily that it's blocked, but kind of what's I see that, Miss Sequoia.
I'm sorry.
No worries, I did it too. So kind of what Miss Sequoia was alluding to is if they're altered, can they protect their airway?
No.
Nope.
No. Well, somebody else, I think Rosie was mentioning, you put that glucose in the back of into their mouth, and they can't protect their airway, and they start choking on it. Are they going to be able to cough to clear their airway?
No.
No. So they have to be conscious so they can protect their airway. Now, the good hint or the good thing to do is, and that's why I was kind of holding my vape up, is if they can hold it in their hand, they can protect their airway. Okay. They can hold it in their hand, they can protect their airway. What else? How much do you give them?
The whole thing, the whole tube.
A whole tube. Can you give them another one?
If they don't,
Yeah, if it didn't go up high enough, you can give them another one. Or you can give them one for the road. All right. As far as activated charcoal, we don't use that very much anymore. It's still out there, but it's not used very much. Charcoal it's in what we call suspension form. In other words, there's the powder, there's a powdered charcoal within this tube, and there's fluid in there, and you have to shake it up to mix it up. Otherwise, the charcoal being heavier is going to sink to the bottom and concentrate down there, and then they're really just drinking clear fluid. Now, what does that charcoal do?
and if you ingested poison, it's supposed to help.
How?
Binding.
The chemical.
Yes, charcoal binds to the charcoal. Okay. So when you poop, you're pooping out black. Do you know contraindications when you can't use it?
Open. I mean, if they're unconscious, you can because they can't swallow it.
Okay, what else?
Unresponsive. Tacky.
No, that's fine.
I don't know.
I didn't notice stitch there before.
It says that it can be harmful when it's aspirated back up.
Yeah. The other two are ingestion of caustic substances like bleach. And the other one is ingestion of heavy metals. So like iron supplements. We do not give it in those situations. Okay. Like I said, it's not used very much anymore.
So what do they use now? Then? If they, I know you could use Narcan for taking pills, but what do they do? Like if they do,
Well, Narcan is for narcotics.
yeah.
Heroin, fentanyl, codeine. No, they don't use anything.
Do they just pump your stomach out now?
Well, they did that before anyway. The next one is aspirin. What can you tell me about aspirin?
It's an anticoagulant.
What does that mean?
Prevents clots.
Keeps platelets from sticking.
Okay. It prevents clots by preventing the platelets from sticking together or clumping up. Okay. Why is it given to chest pain patients?
Is to deliver the blood. It's like from completely closing off the artery, so they have a higher chance of getting blood throughout the.
Preventing inflammation.
Here's a blood vessel. Okay. Here's plaque. Here's whatever it is that's reducing the lumen of the artery. So as a blood flow is going through here, when it gets to this area right here, it creates what we call an eddy, kind of like a riptide. It kind of doesn't allow all the blood flow to go through, so that kind of just swirls around right there. Well, what do the platelets do? They cause the blood to clump together, right? Stop bleeding. So now all of a sudden we have that clot. So what happened to that blood flow?
Stop.
It stopped. So with the aspirin, we're trying to prevent that clot from occurring. So that's why we give it to chest pain patients, to make sure that the blood doesn't clot up and cause a bigger issue. Now, years ago, there was a Bayer commercial, Bayer aspirin, that used to say to prevent a heart attack or to stop a heart attack in progress, take some aspirin. Well, they got in trouble for that. Because, I mean, that's part of the treatment, but that's not going to stop the heart attack. But we do give it for chest pain patients to make sure. Now, so obviously you wouldn't give aspirin to a patient that is allergic to aspirin. What's the dose? Anybody know?
81 milligrams.
Well, it depends for this baby aspirin too.
Well, 81 milligrams is a baby aspirin. Normal
For baby aspirin
5
or
milligrams.
Would you need
Norm,
four?
norm,
Wait, what?
Four if like you're giving a dosage, isn't it 4 baby aspirins?
Yes. So usual dose is 4 baby aspirin, which is 324 milligrams. All right. Anything else? Nope. That's all I could think of for now. All right. The next up is albuterol via an inhaled bronchodilator. It's given in a meter dose inhaler. What does that mean?
It's to help smooth the like smooth and relax the muscles of your lungs.
Okay, so that's the action of the albuterol, is to relax bronchial smooth muscle, to bronchodilate.
But it's to increase the airflow though,
Uh-huh.
or improve oxygen delivery.
Oxygenation. So that's going to be the action, what the medication does. But the delivery device is a handheld nebulizer, or I'm sorry, a meter dose inhaler. And what a meter dose inhaler is, that each dose is metered. It gives so much medication. And so they're prescribed, usually take 1 or 2 puffs as needed for asthma. So did Paul go over how to administer a meter dose inhaler? That was kind of a forced yes. So how do you do it?
Orally, basically.
Okay.
And then you make inhale and then
humidifier.
Mm-mm. A meter dose inhaler is not a nebulizer.
no, it's that little.
How do you help a patient with a meter dose inhaler? You guys said Paul showed you.
I don't remember him showing me.
Not inhaler.
Mm-hmm. You're going to shake it up. You're going to tell the patient to take a couple deep breaths. Once they get the peak of the last breath, do the 1 or 2 puffs, and or I'm sorry, not when they reach the peak. As they're reaching the peak, they take the 2 puffs. They reach the peak. They're holding their breath, so that way the medication goes down into their lungs. Okay, but you got to make sure you shake it up before administration. Now the nebulizer is where you unscrew the base from the cap. You input or you put in the medication. You do 1 or 2. Put the cap back on. You put the T on there. You put the mouthpiece and then the tube. The only bad thing about that nowadays with COVID is that mist that comes out might have the virus in it. So they're saying maybe use more of a meter dose inhaler. Okay. Now,
You know, there's you know that they were saying that there's a new study saying that it's not easily spread now.
Yeah, I didn't read the thing, but I saw the headline.
Yeah, it's
The CDC is changing that.
what it.
Mm-hmm. I don't know what to believe anymore, to be honest with you.
Me too.
Now, what are you putting in that chamber for the treatment? You guys just did this with Paul.
What chamber?
Nebulizer chamber.
Oh, albuterol.
Okay. Anything else?
You can dilute it with water.
You said to dilute it with water?
Yeah.
Don't. That's why I'm checking. Do not dilute it with water, because then you're giving the patient less medication than they need. It does not need to be diluted. Just give the albuterol bullet. Did he show you an albuterol bullet?
Yes.
Yeah, it did.
Okay.
Yeah.
So just put that in the chamber and that's it. No saline. Do not dilute it. Okay. You guys got that?
Yes, sir.
Yes.
Yep.
And then what do you do with the oxygen tubing?
You give it some in the mouth, or give it from orally.
Okay, you attach it to oxygen. How much oxygen?
Isn't it 10?
8.
8, there you go.
8 liters per minute.
Yes.
Okay. All right. Any questions on the bronchodilator?
No.
No.
Okay. Am I going too fast for you guys?
Okay.
Okay. So next up, nitroglycerin. What does nitroglycerin do?
Isn't it a vasodilator?
And dilate your
Blood vessels. Yeah. Nitroglycerin is a vasodilator. Like we were talking earlier about that blockage. When somebody has some sort of chest pain, we give albuterol. I'm sorry, we give nitro. I'm muting you. Oh no, you're good now. We give nitroglycerin to help open up those blood vessels to kind of restore blood flow because they're being constricted for whatever reason. So nitroglycerin is given just for that. Now, we know that nitro is a vasodilator, which opens up the blood vessels. Before you administer nitroglycerin, though, what must you be sure of?
they don't have a low blood pressure.
Okay, the blood pressure has to be high enough. What does that blood pressure have to be?
Above 90 systolic.
There you go, above 90 systolic. Although most protocols will say over 100. But for National Registry, you have to remember 90 systolic for the top number. What else must you be sure of?
Mental.
Okay, I'm not so worried about that one, though. Yeah.
They have no
That's-
trauma in the mouth.
Excuse me, thank you. What was that, Rosie?
They have no traumatic injury in the mouth.
Well,
I have
Mm,
it though.
I mean, it's sublingual, so you put it underneath the tongue. It will
under the
dissolve.
tongue. Yeah. Isn't it like if like they've taken any
You make sure
any
that
other
they haven't taken like erectile dysfunction medication.
There you go. Yeah. That's what it was. Yep.
All right. Yeah.
That's what it was, bro.
You have to make sure they have not taken any type of erectile dysfunction drug prior to administration. And depending on the medication, it's either 24 or 48 hours. Because what happens is those medications are also vasodilators. In other words, they're opening up to improve blood flow to certain areas. Now, can women take Viagra and Levitra and stuff?
Yes.
Yes.
Yes, they can.
Controls your blood pressure.
Hmm?
It controls your blood pressure.
Can they take it for other reasons?
No.
Yes, they can.
Besides blood pressure, what?
Huh?
Besides the blood pressure, what else?
To help improve their sex lives?
Yeah, it's Viagra.
It's a good time.
Yeah.
I mean it that way, God.
Yeah, there's a medical reason for it, pulmonary hypertension, but also women take it to improve their sex lives. Can you imagine Grandpa Jones and Granny Smith?
You know what Viagra is for women though, right?
What was that?
Rosie?
What?
Do you know what the Viagra is for women though? Don't you? It's for lubrication and for like orgasms.
Damn.
Yeah, they don't have to worry about KY. Just take a Viagra and Grandpa Jones is going to town.
K1.
Wow. Oh.
I'm trying to make it PG here.
Oh, sure.
Yeah.
Yeah, with us. Good luck with that.
I like how Lewis knows all about that stuff.
Who, me?
Damn.
Damn, Lou.
Yeah.
Let me find out, Lou.
Trying to say that you're using it.
I'm using what?
Let me find out, Lou.
I know, Lou knows all
It
about
was
that.
Sequoia that mentioned that.
How did I get involved in this?
They're saying it was me that knew that stuff. It's like this is the first time I've never had to tell people what happened because somebody actually already knew. Remember, she worked at an old folks home, so what she's seen, I don't know if we want to know.
Trust me, you don't.
There are freaks in there.
And believe it or not, after Viagra, the number of or the amount of sex in nursing homes increased greatly.
Yep.
Because now Grandpa Jones didn't have to worry about not being able to meet expectations. He met and exceeded the expectations.
Damn.
Hey, even old people need loving. Wait, anybody say anything about my age?
Let me find out, Lou.
Blue, right?
What was that?
You want to go to the drink, Lou?
I can't hear multiple people are talking at the same time. What'd you say, Sequoia?
I say you're 21.
I'm 23. I wish.
No, 21.
Oh, I wish.
Hey, I'm just trying to make you younger.
Just say yes, Lou. Come on. Go with the flow here.
I'm trying, but I was still an angel at 21.
So you say.
Oh no, I was.
Mm-hmm.
What were you saying, Rosie? You're gonna look at what?
What? I don't know.
You're saying you're gonna look something up?
I am? I didn't say that.
I don't know. You kept trying to tell me something, but I couldn't hear you.
I don't remember.
That you're gonna look up the information to confirm what we're saying. Now who's old? Who's having a senior moment?
Do you want me to give you your medicine?
Damn, Lou.
I didn't say it. That was Sequoia.
Some blue wants some painkiller.
It was Sequoia. Look at her.
I had nothing to do with this.
I swear it was Sequoia that said it. But anyway, so yeah, just remember, women can take it. It does, and exactly for that, as Sequoia said. And I have the recording to prove it was Sequoia.
There was a glitch in the computer, so I don't think you got that.
We'll find out. So yeah, just be careful. Just make sure you ask. You're checking blood pressure. You're checking any type of erectile dysfunction drug. All right.
Wait,
And actually, I'm trying to find some containers here.
I had a question. So, if a guy doesn't want to tell you, you could obviously see he has an erection, correct?
Well, it might be because he just saw you. I don't know.
A little excitement there.
I wasn't talking about you specifically, Rosie. I'm just saying.
Anyways, my next question. If a female does not tell you she has taken any and you can't really
Prove it.
see, yeah, so what do you do then? And she's not going to tell you, oh, yeah, I took Viagra, especially if she's talking to a male. How would you do in that situation then?
Um,
I got you thinking, you see?
I think it would depend on the situation, where they're at, and whether there's a guy around. Because remember, women are even freakier.
Yeah, but they don't tell. They don't kiss and tell.
Yeah, women are pretty good about keeping secrets.
No.
Hey, the guys don't stay behind, so don't pick on girls now. Pounds of Koya.
Right?
All right. So let me give you a little demonstration of what happens and why taking both of those together can be bad. Now, this is not to scale. Just clarifying that. This is not to scale. Here's a pill bottle. It's Tylenol, by the way. So here's my container. And there's a fixed amount of fluid in here. Now we take nitroglycerin, which is a what?
A vasodilator.
It's a vasodilator. So it's going to open up the blood vessels. However, has the volume changed?
No.
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 So here's my new container. From this to this. My container's bigger, but then my volume changed. No. How much stretch is there on the arterial walls? In other words, what's happening to that afterload?
Decreasing.
Decreasing?
Abby gave me this one. See my logo? No, my afterload is not increasing.
It's decreasing.
It's decreasing, right? Because my volume didn't change. My container got bigger, but my volume didn't change. So there's less stretch. Now, we take the little blue happy pill. Again, my volume didn't change, right? But my container got bigger. So what's happening to my blood pressure?
Increasing.
No,
Decreasing. Still
It keeps
it's decreasing again. Bigger container, same volume.
Oh, it's decreasing.
Same volume. Big difference, right? So that's why the patient becomes hypotensive. Their blood pressure drops because they have a bigger container, but their volume didn't change at all. Okay. So did you like my little demonstration?
Yeah.
Yeah.
Made it nice and visual. Better visual than Sequoia left us with.
Yeah, pretty much.
Yeah.
I think everybody's bored because everybody's not even paying attention.
Yeah, just next time you're kind of losing interest in class, just think about Grandpa Jones and Benny Smith knocking boots.
Oh man.
Hey, we all got here somehow, you know.
How many babies are gonna be born because all this quarantine?
It's gonna be another baby boom.
No comment.
Too much
Yeah.
quarantine.
This is the generation of Rona babies.
Yeah, it's gonna be the Rona generation instead of Gen
The
X.
Rona generation.
Millennials is gonna be the Rona generation.
Yeah. That's gonna be known by.
There's a meme that I saw that says like they're gonna name their kids Rona, Corona.
Mona.
COVID. Well, when there's nothing else to do, you know.
Besides cleaning.
That's you, Rosie.
I'm tired. I got tired of cleaning. Like I know where everything's at.
We'll get out some.
Tell your daughter to destroy the house and you can refix it.
Oh, I'll kill her. I'm a clean freak. I'm sorry. I'm OCD. You mess something up, I will.
But then you know what? Come on over, help me clean that back room.
No, I'm good.
I thought you're a neat freak and you got to be cleaning. I need help cleaning.
So do you want to
For
clean a whole
extra credit,
two-story
I'm
house
down.
for me too?
What was that?
So you want to clean a whole 2-story house for me too?
No, I'm good. You pay me, I'll do it.
I'll pay you in
Feed me. I'm fat like that. I'm down.
food and beer. That's all you get.
Oh, I'm on my way. I'm not tired no more.
Hi, Rosie. All right. So next up is epinephrine, EpiPen. What can you tell me about epinephrine?
Severely allergic reaction if someone is suffering from it.
Okay. The cool thing about epinephrine is that it has, and it's naturally released, although epinephrine is synthetic. It's not natural adrenaline. It is synthetic. So somebody might, believe it or not, might have an allergy to epinephrine. But it has beta 1, beta 2 properties, as we know from learning the other stuff. So it does what to the blood vessels?
It dilates.
No.
Constricts.
It constricts them.
Vessels that constricts. Because remember the allergic reaction, what's happening to the blood vessels?
They're constricting.
No, they're dilating.
They're dilating.
Oh.
Yeah, dilating.
Just say the opposite of what you're thinking, Rosie.
Wait, we're talking about epinephrine, not when you're going in an anaphylactic shock.
Correct. But epinephrine is going to constrict the blood vessels. But I was asking, in an allergic reaction, what's happening to the blood vessels?
They dilate.
They dilate. And remember the capillaries? So right now they're normal. As the vessels dilate, they start becoming permeable. So what do we want to do so they stop leaking?
Constrict.
We want to constrict it. And that's the alpha properties. Now, what about the beta properties? What's happening with epinephrine when it's affecting the beta?
It dilates.
Constricting the bronchioles. Oh no,
No, it's dilating
dilating, yes.
because allergic reaction is constricting the bronchioles or building up fluid in there. So epinephrine is going to relax smooth muscle, bronchial smooth muscle, opening up the bronchioles, let more air in. Okay. So, what's it going to do to the heart rate?
Increase.
it's going to increase the heart rate.
Exactly.
Mm. All right, Narcan. What is Narcan?
It reverses opiate intake.
Okay, Narcan is an antidote for narcotic overdose. So what are narcotics doing to the central nervous system? Anybody know?
Compressing.
No?
Wait.
Well,
What is it?
it's depressing, but exactly what is the action of opiates on the central nervous system?
I know it slows it down. It compresses the nerve system.
No, it doesn't compress it. It depresses.
Depresses, like it slows down. The Narcan binds with the opiate receptor sites.
Okay, so here's a nerve. So the area in here would be a synapse. It's the gap, but I don't have the next nerve. But anyway, so these are receptor sites. These exon. There's other receptor sites too. We could have the nicogenic. So I was kind of drawing the triangle. So you have the squares, just so you can see it. And I put some triangle in there. So a different type of receptor. So the opioids are these right here. They're going to go into that receptor site and cause respiratory depression. It's slowing down the respiratory rate. It could even cause the person to completely stop breathing. A drug OD. So it depressed the system so much the person stopped breathing. We give them Narcan. You notice how they're the same shape as the opioids? And so what happens is, let's just switch these two around now. So what happens is, now these are the opioids. What happened was the Narcan came in and kicked out. So you see the arrows right here? The Narcan came in and kicked out that opioid out of the receptor site. And the Narcan went in there and took its place.
So does it reverse the effect?
Exactly. It reverses the effect.
Yeah.
So, which reminds me.
Stay away when you do that. I hate slow computers. Hi, Mr. Luna.
How you doing, sir?
Good. You want to talk to the class since you never even talked to them before?
Who are they?
It's the morning. It's the morning EMT class.
Sure, let's talk to them. A little bit of
Hey,
trouble you're causing them.
oh, guys, be nice. My big boss is here. He's right there.
How's everybody doing?
Good afternoon.
Good
So
afternoon.
this is Mr. Luna. He's the executive director here at ProAction. So he's the head honcho for the organization. He usually talks to the EMT class the first day, but because we've been online, he hasn't. But he walked in. I'm like, you want to talk to the class? So here he is, Mr. Luna.
Yes, of course, one of the things that I always start with when the new classes are coming in is to tell you something good about the organization. And the thing that we have our best in this organization is the instructors are one of the most dedicated ones. They're very professional and they know their stuff. So you're in good hands. I guarantee you that. This is the thing that we kind of are proud of, that we are able to help you guys succeed in what you want to do, especially with the beginning with the instructor that is very qualified, he's very dedicated, and he has proven to be a person that is successfully completed and helped completed some of the classes that have accomplished. So anyway, let me start. I can see you on the left. What is your name, young man?
That's Gerardo.
Gerardo.
You're still muted. So I could kind of see. And I only got 9 cameras up, but there's all these people in here.
Waiting.
Yeah, they're in there.
Okay, well, whoever is, can someone kind of say, here, you're there, where are you? All right, what is your name?
Rosie.
Rosie.
Aaron.
Rosie, Aaron, and
That's Josh. That's Paul. He's the class vice president. Sequoia left. That's Amber that I see. That's George. That's Luis, mi tocayo. Valeria.
right, good group of
Angel's
people.
over here.
Angel, all right.
Sequoia, where'd you go? She's hiding.
Nice to meet you.
How's
Pleasure
your day
meeting
going,
you.
sir?
Yeah, nice to meet you, sir.
All right, I know that it's kind of challenge to be able to talk to everyone, especially under the circumstances, but I can assure you, as I stated before, our instructors are always willing and ready to help you accomplish what you want to accomplish, and that's to become an EMT. That's what you're here for. I know that one of the things that that people begin to realize with this virus is that EMTs have become one of the major roles in making sure that we stop this virus. And I'm sure as when you graduate, if when you move forward, you're going to be part of that army of people that are trying to eradicate this problem. So I'm glad that you're here with us, and I certainly appreciate your commitment to follow those steps of those other EMTs that have come through our organization and the ones that are actually out there in the rest of this pandemic. So I wish you the best, and if there's anything that I can do for you, you can contact me, and I'll be more than happy to assist you. All right?
Thank
Yes,
you.
sir.
Thank you.
Thank you very
Sir,
much.
thank you.
It was nice meeting
All right.
you.
Thank you.
Meeting you as well. Take care, okay?
Oh, you
We'll
too.
Same to you.
see you soon.
Well,
Thank you, Selena.
Are they using the taco?
Yeah, Michelle might have taken it.
Oh, okay.
She had a monitoring to go to.
All right.
So, yeah, so that's the big boss. He's the executive director, so he's like the CEO. All right, so as we were saying, so the Narcan kicked out the opioid out of the receptor site, and it'll stay there. Unfortunately, eventually it weakens, and the opioid, if they took enough of it, will go back and take its place. So sometimes we can give an additional dose. I want to show you guys. little movie clip. I love this movie. It's kind of dark, but it's an interesting movie. It's primarily about burnout, but there's a scene in here I just absolutely love. And what they show here with the use of Narcan is very, very true. At a entertainment center I used to work at, we gave so much Narcan, and yeah, we would see the patient come right out afterwards.
Did you stand back?
Do what?
Did you stand back?
Yeah. Had a one guy, I remember, he and his buddy split a dime of heroin, and I think this guy got more than the dime, and he OD'd. We finally got the Narcan on board, and it took a couple minutes, but he came out. What is bogging down my internet? Holy cow. I hate it when this happens. Well, I have to put up the volume on my doohickey. All right, you guys can see my movie screen?
Mm-hmm.
All right, hopefully you guys can hear the audio. Can you hear that?
Yeah.
Yes. Okay.
Okay, what? Please tell me it's gonna be all right. No, he did. Why didn't we just sign our first record deal? Look, he did, son. Ain't nothing we can do about it. Come on, Frank, that's it.
What do you mean he's dead?
He's not dead. It's a heroin overdose. Let's break out the Narcan. He's dead unless you folks want to stop bullshitting me and tell it straight. Then the good Lord willing will try and bring him back.
Broke up with his old lady. We didn't break up. We were just seeing other people. Shut up, asshole. Nobody asked you. I told you dead. Shut up.
I'm still waiting and this young man here still's dead.
You want to leave your body back too? You end up like him. Shut up. Dick, shut up.
He's been snorting that red death stuff. It's been going on for like 4 days now. Rebuke the spirit of drugs in the name of Jesus. What's his name? I be banging. What you mean I be banging? I be banging. What the hell kind of name is I be banging? I don't know his real name.
Frederick Smith.
Okay, Freddie.
It's Frederick.
Okay, I be banging. We're gonna bring you back from the dead. Now I want everybody here to grab the hand of the person next to you. Come on now, we ain't got much time. And look up towards the heavens. Dear Lord, here I am again. Asking one more chance for a sinner. Please, Lord, bring back I be banging, Lord. You have the power, Jesus. You have the might. You have the super light to spare this worthless man. Rise, I be banging. And come your life anew, Lord. Oh, thank you, Lord.
You fucking died, you stupid bastard. I warned you.
Damn, you guys are good. Not us. The first step is love. The second is mercy.
Ha 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 ha. Did you guys like it?
Yes.
Yeah.
Yeah.
Dramatic.
Is this from a
This from
movie?
a movie?
Yeah, Bringing Out the Dead.
I've seen it.
Yeah, it's a good movie. Like I said, it's dark. It starts out. He's burned out. He's burned out, and what makes it worse is like he's like every arrest I've been on, they don't make it. I've had too many deaths recently, so he's just going through the motions and everything of working as a paramedic. But it is a good movie. Like I said, though, it's a little dark, so I don't know if you like dark movies or not, but it's a good movie. You guys should check it out. If you're that bored, Rosie, check it out. Maybe it's on Hulu.
I'm not bored.
Up the hole.
What was that?
I'm not bored.
What's the name of the movie?
Bringing Out the Dead. So if the person's in respiratory arrest, Narcan will bring him out of that as well. Okay. You guys got shown the King Airway. They usually recommend that you give Narcan before you put a tube down their throat. That guy I was telling you about, because we didn't have the Narcan available and he was in respiratory arrest, I went ahead and dropped a King Airway in him, and we were bagging him until the Narcan got there. It took a few minutes to kick in, but once it did kick in, he woke up, and he ended up pulling out the tube himself. So it was a good thing because instead of fighting us, he was fighting that tube. But as far as intubation goes, though, that's more at an advanced level, but we definitely want to give Narcan before we intubate them because that's going to be worse. But in general, you want to try to give the Narcan before you do anything else. But it will reverse those effects. Narcan is now available over the counter. You don't need a prescription for it. So, all right. So the big thing about medications that you need to know about is the different types of names that we have or different terminology. The first one is a chemical name. All it is just the chemical structure of that medication. After that, we have the generic name. In other words, like sildenafil is a generic name. Anybody know what the brand name is of sildenafil? It's Sequoia's favorite medication.
It's a Viagra.
It's Viagra. Yep.
Yeah, I'm still here. Sorry, I'm on the phone really fast.
Oh, no worries. So generic name is a name that anybody can make that. However,
Like a cheap brand.
yeah, it's going to be a lot cheaper. The reason being is the brand name is the name that everybody knows. In other words, Viagra, everybody knows Viagra. But the thing about medications is they're covered for about 16 years. They're covered by a patent. And so only one company can make that particular medication. Like Pfizer owns the name Viagra. And for 16 years, they were the only ones allowed to make Viagra or sildenafil. Nobody else could. Now that time has passed, now anybody can make sildenafil. And they market it as sildenafil. So if you have any prescriptions at like Walmart and they say $4 generic prescriptions for 30 days, that's exactly what it is. It's generic names. Diazepam. That is generic for Valium. So it's a non-proprietary name. All right, talked about the trade name. And then the official name is the name that's officially given to it by USP, the United States Pharmacopoeia. So basically it's a formulary of approved medications for the different conditions. Big example, due to COVID, everybody's heard about hydroxychloroquine and chloroquine. Under the USP, United States Pharmacopoeia, hydroxychloroquine and chloroquine are listed as anti-malarial drugs. So in order to use it for something else, COVID, there has to be approval from the FDA to use it for something else. Now they can, and that's called off-label use, where they're using it for something other than what it's normally prescribed for. But under the formulary, the approved treatment or part of the approved treatment for example, for malaria is the use of hydroxychloroquine. Now, I was taking that before COVID started because of my autoimmune disorder. And now because everybody's asking for it and everything, I've been unable to get a refill on that medication because they want a diagnosis to make sure it's not for COVID-related things. So that's the official name of it. Okay. Now, we talked about the different medications and we talked about how they're, we kind of talked about how they're delivered. So we have gases like oxygen, sprays, like meter dose inhaler. What was that? I can't hear you. Suspension. That was what I was telling you about with charcoal, where the powder is suspended in that fluid. Nitroglycerin is given sublingual. Why do you think we would give it sublingually?
And just as fast as
Okay. Because if you've ever looked underneath your tongue, do you notice all those blood vessels there? It's considered very vascular. So putting it under the tongue, it dissolves and it gets in your bloodstream a lot quicker. It's bypassing the stomach. That's what we would call third pass metabolism. It would take about at least 20 minutes before it kicks in when you take a pill. But sublingually, it's almost instantaneously. Same thing with Narcan. When it's given intranasally or IV, it's pretty quick. Although intranasally, it might take a minute or two. But IV, it's pretty direct because it's already in the bloodstream. So that's going around. Remember, a drop of blood takes 3 minutes to go all the way around the body. So it would be pretty quick for it to go. Rosie, be quiet. Then you have oral. It's picking on Rosie. Oral is where you take it by mouth. It's also abbreviated PO, per os, por hocico. This is the way I remembered it. Per os is Latin. So if you use your Spanish, for those that know Spanish, just think of it por hocico. What's hocico?
Wow.
Your mouth, right?
Your mouth.
So that's how I remembered it, por hocico, by mouth, PO. So any type of tablet, you could also have the elixirs, like the cough syrups. All that is oral. Talked about inhalation with the gases, the nebulizer, the meter dose inhaler. We talked about intranasal, up the nose. Epinephrine or the EpiPen, how's that given?
IM.
IM, and what does IM stand for?
Intramuscular.
Muscular. So it's going right into the muscle. You inject it at a 90-degree angle, and it delivers it to the muscle. Now remember, we've talked about the vasculature, the capillaries, right? So that medication is spreading and it's getting absorbed into the muscle, and eventually that's going to get into the capillaries, which in turn is going to go into the bloodstream. So that's how that medication gets around. It ends up getting to the bloodstream via the circulation. Okay. Yeah. So real quick, indications, and just please read up on it. I'll try not to put a lot of these questions in there, but the terms of indications, contraindications, dose, actions. The main thing about indications is what is it indicated for? Like shortness of breath is an indication. What medication can you think of that we would give for shortness of breath?
Oxygen.
Oxygen. Any others?
Albuterol.
Albuterol. So indications is what it's used for. A contraindication, contra means against. So contraindication, like with nitroglycerin, a contraindication would be a blood pressure, systolic blood pressure less than 90, or ingestion of erectile dysfunction drugs within the last 24 to 48 hours.
Yes.
Okay. Dose. How much of a medicine do you give them? The administration is how you give it. Is it a suspension? Is it a tablet PO? Is it sublingual? Is it intranasal? How do you give it? The actions would be, what is it doing to the body? So what's the action of nitroglycerin?
Okay.
To improve blood flow.
What was that?
To improve blood flow.
Okay, that's
Well, yeah, that's
okay. That's part of the action, but what's the bigger action of nitroglycerin?
Dilating the blood.
Yeah, it's a vasodilator.
Yeah.
So the action is what we expect it to do. The action of albuterol is what?
Dilate the bronchial.
Yeah, it's a bronchodilator. Or also you could say it's a beta-2 agonist. That's a fancy word. Agonist is it's for. Word an antagonist is against. So Narcan is considered an opiate antagonist. It's antagonizing the opiate. It's kicking its butt out of the receptor and taking over for it. Okay. And a side effect would be what bad things or what things can occur as a result of that medication. So what's the side effect of nitroglycerin?
Headache.
A headache. A headache. What's the side effect of albuterol or epinephrine?
Dilated pupils.
What else?
High blood pressure.
What else? Tachycardia. So that's kind of expected. Side effects are kind of effects that you might have as a result of this medication. Most of them have a side effect of nausea and vomiting. The rights. After you give the medication, make sure you reassess your patient. What you're trying to do is to make sure that the medication is working like you expect it to work. So allergic reaction, you want to make sure that the patient's not able to breathe, that the allergic reaction or the anaphylactic reaction is being reversed. Okay. All right. Well, I've exceeded 12 o'clock. Like I said, I won't put too much of this other stuff. I won't put anything about the rights. The one last thing I will mention is documentation. After you give it, document that you assisted or you administered the medication.
Yes.
Okay. That way there's proof. Because remember what we said before, the old adage about not writing it down. If it wasn't written down, it wasn't done. Okay. Any questions?
No.
No, sir.
No, sir.
All right. So So like I said, Monday there's no class due to Memorial Day. So we will see each other on Tuesday. You do have an exam. And we'll go over it. Okay. Again, I hope you had fun the last 2 days and coming into class to practice some skills. If you did make it, you want to go over some of the skills, we could set up one-on-one time. Honestly, the best days for me are Fridays because I don't have a morning class. If you do it Monday through Thursday, well, Monday, I have you guys, so it'd have to be right after that, about 1 o'clock or so. So that's the only drawback. But other than that, anybody have anything on anything? Please speak up.
Nope.
No, sir.
All right. I want to wish you guys a happy Memorial Day weekend. Don't forget the reason for the holiday. Be very safe if you happen to do something, both COVID related and maybe alcohol related, which it's never good when the story starts. The guy was drinking, or here, hold my beer. It's never good. I've been around long enough to know.
Where's Sophia? This is her subject.
I think she's still on the phone. But guys, have a great weekend. I will talk to you on Tuesday.
Same to you, Lou.
Okay,
All right,
bye.
Have a good one.
Bye, guys.
Yeah, have a good one.
Take care, Lou.